This is Q&A with Prof. A, the Ibato kay Doc Bato educational series. The question thrown to us today is, Doc Bato, what are the top 5 must-knows in hypokalemia treatment? Number 1, serum potassium does not reflect true potassium deficit. Only 2% of total body potassium is extracellular. It's like the tip of an iceberg, such that when we replace, they are usually estimates, and doses should be quite large to fill up the 98% deficit. Here are some formula estimates from literature. Every 1 millimole per liter decrease is around 100 to 200 deficit of potassium, or every 0.3 millimoles per liter corresponds to around 100 millimoles deficit. If less than 3, so it's around 200 to 500 millimoles deficit. Or some formulas like 3,300 to the exponent of the serum potassium over 1.5 minus 200. Or 100 times 4.4 minus the serum potassium. Number 2, rule out pseudohypokalemia first, seen in leukemias where there is an increased cell uptake of potassium due to the high number of metabolically active cancer cells. Or the high ambient temperature increases the sodium-potassium ATPase activity, increasing potassium movement in the cell. To minimize this, we require for a plasma potassium extraction and place the sample in ice bath during transport. Number 3, priority in treatment. Potassium disorders are life-threatening conditions such that a delay in treatment is usually fatal. So keep in mind that after volume resuscitation, check potassium balance in your patient. Number 4, oral correction is faster, safer, and most effective than parenteral. Evidence shows that in states of prolonged hypokalemia, your colonic hydrogen potassium ATPase pumps increase in number. Among the different potassium pumps, only your ATPase pumps are involved in potassium reabsorption, while the rest are for more secretion. And what better access is using your gastrointestinal tract. Remember, 98% of potassium is intracellular, and to correct the potassium loss, you need a large dose of potassium, which you cannot do with IV, because we all know IV KCl is limited by the concentration and its rate. Too high a concentration of around more than 40 millimoles per liter is caustic to the blood vessel, and too fast a rate of more than 10 millimoles per hour will lead to lethal cardiac arrhythmias and possibly death. But with oral replacement, you can give industrial amounts and not afraid of giving it too fast via the gastrointestinal tract. This table shows you how we give oral potassium. Just keep in mind around 40 to 60 mg per dose every 2 to 4 hours. From our extensive experience, unlike IV, we can confidently say that we can increase the serum potassium in less than 24 hours. Caution, however, only if the enteral route is not compromised. Otherwise, the patient cannot tolerate oral replacement. We have to do it intravenously. Number 5, treat the underlying cause. Always ask for losses. Is the patient polyuric? Is there vomiting? Is there diarrhea? Just treating the volume alone will actually correct the hypokalemia. Certain diseases and drugs can increase potassium uptake intracellularly. In this case, aggressive IV correction may not be necessary. Treating the disease and removing the implicated drugs will mitigate the condition. And if you have refractory hypokalemia, check magnesium levels. Low magnesium enhances your ROMK channels, or renal of the outer medullary potassium channels, to secrete potassium. The top 5 must know in hypokalemia treatment: Number 1, serum potassium does not reflect true potassium deficit. Always rule out pseudohypokalemia first. It is a priority in treatment, secondary to volume correction. Enteral correction is faster, safer, and most effective than parenteral. And finally, number 5, treat the underlying cause. For more high-yield concepts in pediatric nephrology, do not forget to click the subscribe button.